All right, welcome back to Cultivating Connections in the Time of COVID. I'm Amanda Brosana-Rios, the Communications Director for National Grange. And today we are talking about a topic that we talked a lot about before COVID. And then somehow it was as if the oxygen left the room and there was no more space to talk about something that is still a big issue, and that is the opioid crisis, especially in rural America. I am by no means an expert on this subject. And so, as you know, I like to bring in those people who are. So today I have Mark O'Brien with us, and Mark is a recovery and addiction specialist and works with RALI, which many of our state Granges are partnered with. So, hey, Mark, how are you?
I'm doing all right, Amanda. I'm so grateful to get to be a part of today's event. And so thanks
Well,
for having me.
we're excited to have you because we have had such a fantastic partnership in several of these states, including Maryland, where you're at, with the RALI chapters. But since I know a lot of people don't know about it, I really wanted to get you on here to talk about what RALI is first, and then talk about this opioid crisis, because I think we can probably both agree that just because there's something major like a COVID crisis happening, that doesn't stop some of these other things in life from going on.
That's exactly right. Yeah, and I think it makes a lot of sense that the coronavirus and the pandemic would be taking up a lot of our attention. It's sort of like devastation on the scale that we've seen with the opioid epidemic, but just in a really condensed amount of time. And so it makes a lot of sense, but I completely agree with you that it's taken a lot of our attention away from a crisis that hasn't gone away, isn't going away quickly, and will be here when the coronavirus does go away. So I've been working in the field of addiction and criminal justice for a little over a decade. I got started with a public policy organization in DC called Legal Action Center, doing advocacy work to improve access for people who need drug treatment through federal policy. I was there for 7 or 8 years and then went to the Baltimore City Health Department, where I was the director of overdose prevention and treatment. And then I was with another nonprofit called Addiction Policy Forum, where I got to work with communities all around the country, state and local jurisdictions, rural communities, urban communities, on their strategic plans for how they can respond to the opioid crisis. And I give you that background to tell you, to sort of segue into telling you a little bit about RALI and why I'm so excited that I get to be a part of RALI. So RALI stands for the RX Abuse Leadership Initiative. And it really is a convening body that brings together diverse stakeholders, all perspectives, to talk about the issue of the opioid crisis, to identify the challenges and problems that we're confronting in addressing the opioid crisis, to identify what's working in different places, and to highlight and sort of elevate those solutions. And the reason that I'm so excited to be a part of RALI is that, in my experience, this really is what has worked in communities that have started to turn the corner on the opioid crisis. And what I mean by that is that those communities are all bringing together these diverse stakeholders, whether it's public health and law enforcement and criminal justice, that you'd probably expect to be at the table on an issue like this. But then also employers, groups like the Grange, libraries, educators. In Baltimore City, our rec council was a big part of how we responded to the opioid epidemic. And so it really is saying that this is a crisis that affects people from all walks of life. But it's an all hands on deck kind of situation where we want everybody involved in being part of the solution. And that to me really is the biggest factor with RALI, is that in each of our 14 state groups, we bring together those diverse perspectives to share information, to educate people's networks and the folks they work with, and to really raise awareness.
That has been such a great and successful model. And I think that I guess what I want to say is, it's so easy for us, the Grange, 150 plus year history, to look at things like rural free delivery and rural electrification and stuff, where one organization like us was pounding the doors and was credited with turning the corner on some issue. And today it doesn't seem, either because voices are fragmented or because we have such a greater population or because we have such a diverse population or because we're caring about so many more issues than we may have at one point in our history, that one group can really turn the tide. And so I love that this is a stakeholder process. And I love that we are part with, as you said, educators, libraries, criminal justice system, everybody and anybody in a community who can help people be steered away. And I think, being a part of that is so important, even though it doesn't sound as sexy as, being the one to make the change, right? But this stakeholder process does work, just like you said.
Well, I love what you just said about, I love a lot of what you just said, but I think the point that you raised about our society being really fragmented right now is one of the reasons that it's so important to have so many different stakeholders at the table. And what I mean by that is that we really have become very polarized in our country, whether it's left and right, Republicans and Democrats, rural and urban, and we're also inundated with different different media all the time. Each of us has media outlets that we probably trust and some that we trust less. And so it really is important, I think, in this space. And I think this is one of the issues where, as a country, we've done a good job of this with RALI, but also just more broadly, where we're saying, Democrats and Republicans, left and right, people from all walks of life, different races, different religions, we all agree that this is a huge problem, and generally agree on what a lot of the solutions look like. We may think that different parts of the solution should be prioritized in different ways, but I think it is really important to say, we're all in this together, and whoever that trusted voice is for you, we want you to hear from them about what the problem is, what the solution is, ways you can protect yourself, ways you can look out for your loved ones and your family and your community.
And I know I'm getting ahead of kind of where we want to take this conversation, but I just want to say that for me, one of the most wonderful and exciting parts of Grange is the fact that we are a nonpartisan organization that deals with issues. We're not nonpartisan and then stick our heads in the sand. We know that there are things that have to happen in our communities that requires us to be informed and it requires us to be advocates, but we come to the table kind of with open ears. And I think in the places where we have been working with RALI, it's nice to have voices like that in the room who don't get labeled with an R or a D or anything else, or it can't really be, because we do work on such various issues from such different perspectives sometimes, that we're able to kind of moderate some of those voices that, good, bad, or indifferent are coming in with, that R or D label or whatever.
That's right.
So I wanted to kind of take us back, because I think most of us know and understand how big this opioid crisis is or was or will continue to be. But I think it's really good to kind of set the scene. So turn of 2020, we have been dealing with this opioid crisis really for about 25 years. We just haven't quite acknowledged it as that for that long. That's correct, right?
Yeah, I think that's exactly right. And I think it's important to really look back through that history. And I think part of that was good intentions gone awry. We really started through the late 80s and early 90s in the healthcare field to think about pain as a really important part of an important thing that we needed to address within healthcare. We had new opioids coming on the market to treat pain. We had accreditation bodies that were saying, hey, part of the way you're going to get reimbursed is going to be based on how your patients rate your ability to take care of their pain. And so there really was this well-intentioned, strong pressure to start really treating pain pretty aggressively. And the solutions that were on the market were opioids. And so we started seeing prescriptions for opioid medications go up dramatically. And then in the early 2000s, we really start seeing this problem to start develop, where we have this explosion of the use of opioids for valid medical reasons, but then also misuse becoming more prevalent just because there was greater access, and people can easily become addicted to these medications.
and we weren't talking about how addictive they were. I mean, I remember that it was only probably in 2017 or 18 that we started hearing that it could take you just a few days on these medicines to become addicted. I mean, before that, we thought, well, you had to have a 30-day prescription at least, right?
Yeah, that's right. Yeah, and I think so. We start seeing this attention being paid to this problem of overprescribing, and we get prescription drug monitoring programs, more education of providers about these risks, more education of patients, because I think part of this is also patient expectations coming into the doctor's office where my back hurts, I've got something going on. The doctor's going to solve this problem with a prescription. I'm hurting. And it's, of course, we want that to be solved. So more education all around. We start seeing the prescription numbers come down. And, at that time, what we saw is that a lot of people who didn't know, may not have known that they had become addicted to opioids because they were being prescribed by their doctor and they were taking them according to the prescription. All of a sudden, were going into withdrawal, they're getting sick. And we see cheap, potent heroin start to flood the market at around this time. And our opioid epidemic, really, we talk about this having multiple phases, went from being a prescription opioid epidemic to a heroin epidemic. And we start seeing the prescription drug overdoses go down. At the same time, we start seeing the heroin overdoses going up. And then, of course, we in the last few years start seeing the synthetic opioids, fentanyl, carfentanil.
Mark, I think you've frozen on me. Hopefully we'll get you back here in a second. I can see from our live stream that I'm still live. So Mark
has spoken for me.
There you are.
Okay, good. So I was just saying, I think your screen froze for me, so I'm hoping that I have stayed connected. But we get to around 2017, where I am cautiously optimistic we really hit the peak of this thing. And I think with COVID-19, we're all starting to learn a little bit more about how epidemics don't necessarily have this bell-shaped curve, but they do have, an upward trajectory and then a flattening of the curve, which we've all become familiar with, and then a decline. And but even at that, as we start to hopefully see a decline, and I'll talk about that in a second, we're still talking about a tremendous amount of destruction and a tremendous number of lives that have been cut short. In 2017, we lost 70,000 Americans to drug and alcohol overdose. And, I always think that's really hard to fathom. And now as we talk about the coronavirus, I think we can relate, it's just hard to fathom that number of people dying. But 70,000 people in 2017 meant that 192 people died every day, like an airplane crashing every day. And to get even more granular, it means that 192 families had one new empty seat at the dinner table every single day. And so it really is just a tragedy, because we're talking about people's moms and dads, we're talking about people's brothers and sisters, people's neighbors, coworkers, friends, dying in just these unfathomable numbers. And to me, the really tragic part of all this is that every single one of those deaths is preventable. But we did start to see in 2018, and we don't have 2019 final numbers from the CDC yet, but in 2018, we did start to see those numbers decline for the first time in a really long time. And in 2018, we went from those 70,000 deaths to 67,000. And still an unfathomable, unacceptable, tragic number of people whose lives were lost and family members who are grieving. But we did start to see that dip. And it's way too soon to pat ourselves on the back. And it's, not a good idea to let our eyes off the ball while we're focusing on some other very important national crisis that's going on. But it is a reason to be hopeful.
One of the things that I think I want to also kind of set up in this is we started seeing this crisis because there was an overprescription issue. And we've already had a question come in, how can this be legal that you have so many prescriptions being written by some doctors. How is the drug supply chain kind of not figuring this out, regulating it a little better, whatever? Where did that play into this crisis? And secondarily, it's really easy to just push it off as these are medically necessary, but it was when we started seeing the heroin overdoses in populations we never thought we would see them in, that this seemed to really get attention. So can you talk about those two issues a little?
Yeah, so I'll take the second one first, and I think it's something that we'd be remiss to not acknowledge, that this isn't the first drug crisis that we've had in this country. We had heroin before in the 70s. We had crack cocaine in the 80s. And the ways that we've responded to drug crises in the past, especially when they've been centered in urban areas, and especially when they've been centered around African Americans, have been a lot different from the way that we've responded to this crisis. And I don't want to beat people over the head about that, but I think we have to acknowledge that we took a very punitive, very criminal justice focused approach to those past crises. I think there's a history of racism in this country that is a part of that conversation. I also like to think that we've maybe learned something from the fact that those approaches didn't work really well. And that is also part of why we're seeing a different approach that focuses on treatment and public health, and hopefully to the benefit of all communities that are suffering because of this opioid epidemic. Now, to your first question about the overprescribing, I completely agree that was a huge part of how we got into this mess. And I think there have been questions raised about the way some of these medications were marketed, about providers who prescribed them either inadvertently in large unnecessary quantities, and probably a small subset of those who were doing it in a way that really wasn't above board. And I think what we've seen is that the DEA and the CMS, the Centers for Medicare and Medicaid Services, who kind of regulate those programs, have started to crack down on providers who are seen as sort of like way off the charts, what we would call like a pill mill, where their business model seems to be sort of predatory on people who may or may not be seeking pain treatment, or who may or may not be seeking drugs because they already have an addiction. But I think the much larger issue has been providers overprescribing because that was the tool they felt they had in the tool chest to address pain. So a big part of what we're doing now is really educating providers. And so I talked about the prescription drug monitoring program. Basically, I think the questioner is getting at, like, how did this kind of not get on the radar? And that really is the purpose of the prescription drug monitoring programs, is one, to identify providers who may be prescribing at higher rates than other providers. And that could be for a variety of reasons. We're not gonna crack down on a provider who's treating terminal cancer patients with opioids. We're going to treat those folks' pain pretty aggressively. Or if your practice is really centered around pain treatment, and you're also providing other services to try to get at the root of that pain, you're probably going to be prescribing more pain medications than a primary care provider. But it kind of highlights this for us. The other thing it does is it allows us to identify patients who may be getting prescription opioids or benzodiazepines, other controlled substances, from more than one provider. So that was also a part of this in the past, was that people would become addicted, and providers didn't really have a great way of communicating with each other if there were prescriptions coming from more than one provider. And pharmacies might not know about it if that person was going to more than one pharmacy. So now all of these systems are able to communicate with each other and identify those patients, so that hopefully the provider is not just turning them away and saying, get out of my office, but educating them about the fact that they may have a problem, identifying where they could get some help, but also, discontinuing the overprescribing and being able to communicate that with other providers who might be offering opioids or other controlled substances to that patient. But then what we're also doing is, again, if you're really over the top, law enforcement is probably going to get involved. But for the most part, if we're identifying a provider through the PDMP who may be prescribing at levels that are unwarranted, is reaching out to that provider and saying, hey, we wanted to let you know that compared to other providers in your area, you're prescribing opioids for a longer duration, higher doses, more frequently, whatever the case may be, so that they hopefully will do some self-correction. And we have, and I'll say the result has been that we have seen those prescription numbers and the duration and the dosage drop off significantly.
And I've heard someone talk about this as it was an inevitable crisis for rural America because we have we have labor as part of our characteristic. Manufacturing facilities often are in rural America. Farming, ranching is a dangerous and body beating industry. We have older populations with different types of chronic conditions and just conditions that happen by age that require pain management of some ways. And in rural America, there's not a lot of other options. You don't find acupuncturists, you don't find natural remedy, herbalists and things. Whether or not you believe those work, you don't find a lot of other options just sitting in your backyard in a lot of rural communities. And there's fewer doctors who have less time to spend with the patients to kind of keep some of these things in check. So have you heard much about those issues and how rural America really ended up becoming kind of where this exploded almost the most?
Yeah. So one, if you had asked me that question before your preliminary comments, I would have given almost the same answer. Like you nailed it. You described this really perfect storm. And I think what you talked about with the type of industries in rural communities, agriculture, manufacturing, a lot of hard work that's hard on the body. And also, I think another part of this is work that doesn't always provide paid leave, disability payments. If you're a private contractor and your family and your coworkers are counting on you, you also want to get back to work. And this can be a quick fix that allows you to get back out there when maybe you do need physical therapy, chiropractic, and like you said, those things may not be as readily available. It's going to be a lot tougher for you to get to that physical therapist once or twice a week. The job is not slowing down because you feel like you need to slow down. So there's this labor part of it. There's the providers that are not as readily available, don't have as much time to spend with you, and also have probably, because there are other folks in the industries that you're working in, have gotten more comfortable with the idea of giving somebody a pill so that they can go and get back out there. And then a third thing, and I'll put in a little plug for a book I found very interesting, Dreamland by Sam Quinones. If you haven't read it and you're interested in this topic, I think it does an amazing job of kind of laying out this storm of factors. And this third factor that, as we moved kind of from the opioid, the prescription opioid phase and the heroin epidemic, kind of, it didn't just like the prescription opioid epidemic ended and then heroin happened. It was already happening below the surface, and the prescription opioid epidemic didn't just go away. It slowly has petered out a little bit, but it's still a big part of this. There were some drug cartels in Mexico that started to explore new ways of distributing heroin, and their goal was really to find sort of mid-major, Midwestern, old Rust Belt cities, in the like 1 to 200,000 population range that are typically surrounded by lots of rural areas and not well serviced by other drug cartels. So their whole business model was to go into these cities that historically had not had a lot of drug trafficking because they didn't have to compete and worry about violence. And they developed these really lucrative and sort of just some really strong business practices around distribution that made it harder for law enforcement to detect, more convenient for people who wanted to buy drugs, and they were selling at prices that were well below what people could get prescription opioids for. And so at the same time that we have people getting more access to prescription opioids, we have heroin coming into these communities where it really wasn't available just 10, 15 years ago. And so I think that was probably the one additional area I'd say that contributed to this really taking off in rural communities.
Yeah, I mean, I know that we also hear a lot about these rural communities where they're kind of pass-through communities. They've got an interstate running through or nearby, and they're easy locations to just take and distribute or take and drop off, and places that hadn't been, the hub prior. So I think, that's the other thing that wasn't noted in that initial discussion that I saw, but is absolutely something if you're dealing with law enforcement issues, you probably know. What are some of the hardest things when combating this crisis, and how is having this partner model, important? And then, of course, I'm going to get to COVID and where we are now. But
yeah, I think the hardest thing about this crisis, and I would say this even if the second part of the question wasn't around the partnership model, is that so much of the way we address drugs has historically been very siloed. So law enforcement and criminal justice did their thing, which was, we're going to arrest people for selling drugs. We're going to arrest people for using drugs. We're going to put people in jail. And that's how we're going to solve the problem. We're going to take the people who are involved in the problem and put them in jail. Then you had, public health that was doing things like harm reduction, trying to make sure that people had clean syringes, so that if they were using, they were not spreading infections and things like that. But weren't necessarily working with law enforcement to get at the root of like, well, how are these drugs getting into our community? You had the healthcare system where, providers really weren't educated about addiction in general up until the last 4 or 5 years. If you went through medical school, you probably didn't hear a lot about addiction. And then you had the addiction treatment system, which for historical reasons grew up completely outside of the healthcare system. So they weren't talking to each other. If you were getting drug treatment, your primary care provider probably didn't know because you were ashamed to talk about it. Your addiction treatment provider didn't know that you also had diabetes because you didn't think that was relevant to the conversation around your addiction. And so all these systems were not talking to each other. And then because of the stigma around substance use disorder, employers weren't talking about it because their employees sure as heck didn't want to talk about it. Families weren't telling other families about it, so it wasn't coming up a lot at church. Educators didn't really think that this was their space. And so you had all these different sectors of society that were really deeply impacted by this well before we had an opioid epidemic, because we've always had millions, tens of millions of people in this country with substance use disorder. So I think that's another important point, is even among this opioid use disorder, we have about 2 million people who have an opioid use disorder. We've got another 18 million people who are addicted to alcohol or other drugs. And so, and that problem, I think we talk a lot about opioids, but I think it's really important to recognize that really what we're trying to address is addiction broadly. But yeah, all these different systems and industries and parts of our community and society weren't talking to each other at all about these issues and ways to address them. And I think the huge benefit of focusing on partnerships through RALI and in local communities, task forces and coalitions that have built up around this, is that all of those parts of the community are together talking about this and recognizing that if you're from public health, there's still a role for law enforcement and criminal justice. If you're from law enforcement and criminal justice, you're starting to recognize there's a role for public health, and treatment and the healthcare system are starting to work together, and employers are starting to talk about, well, how does this, number one, impact my workplace? But number two, how can I support the people that work for me? And then you have faith-based groups like the Grange, chambers of commerce, that represent large groups of businesses and industries and work with different communities, all also recognizing that they have a role in raising awareness and helping to address this, and making sure that the unique needs and also the unique resources of the communities that they work with are recognized, and sort of that we're not trying to implement solutions that are one size fits all, but that we're identifying things that work. At the same time, we're kind of thinking about, well, how do we tailor this to the unique kind of situations of different communities? Oh, I can't hear you.
Sorry, I have to tell you that's why I think also the partnership or Granges being included in this effort, that's where our strength is. We are an organization that does not have top down. While we may suggest state Grange should get involved in RALI, a local Grange should get involved and take part in doing drug takebacks or whatever. We don't force our Granges to do very specified things when it comes to activities and things, because we ask them to judge the needs of their community. And there may be a Grange that just does not have the resources to do what could be done in this fight, but a church that's doing a great job, and yet there may be another community where the Grange can be integral to having some of these drug takebacks, having education nights, doing different things in their sphere. And so I love that the way that your organization is working and the way that our organization is structured really seem to play well together.
No, I think that's exactly right. And this is a big country, and we are a very, very diverse country. And I think there's great wisdom in recognizing that, yeah, we can talk about things and ideas that work kind of broadly, but that we're really a group of unique communities that and that people who are closest to their communities are the ones who know what their community needs. And sure, we want to make sure that if you're in Pickaway County, Ohio, about the most cutting edge addiction treatments, just the same as some doctor out in LA does. But we also recognize that the way that people interact with the systems in your community are going to be very different, and the way that you implement things will also be very different.
Yeah, absolutely.
And you have you have different institutions, even in communities that are very similar. Just because people are part of institutions, you wind up with different institutions that are more or less respected, more or less active, more or less well equipped to do the things that maybe needed to be done in that community.
You mentioned that you have 14 state groups, that RALI itself has 14 state groups. I want to pull to RALI for a second before we go back to opioids in general. What are the 14 states? Do you know them off the top of your head?
Yeah, so I probably won't be able to name all 14, but Maine, Maryland, Ohio, Indiana, I want to say Kentucky, Colorado, New Mexico, Nevada, Washington, Oregon. I think that's all I'm going to get right now. Florida,
Illinois, New Hampshire.
Illinois. Oh, you're good. We got to 13.
We did. We got to 13. I'm wondering if Texas is one of them, because our state president from Texas is on and asking if they can get involved with you. And so just figured
I'd love to connect them, and we would love to find a way to get them involved.
That's perfect. So we will make sure to connect Burton and them and you, and it'll be great.
And there are some states that haven't had official RALI chapters where we've still done events. So I think one of the great partnerships we have is with one of our national partners, Code 3. It's an organization of former law enforcement officers who have put together the RALI Cares trailer. And what that is it's I'm blanking on the word. It's like a a simulation, yes, a simulation of a teenager's bedroom, and you go in there, and these ex-law enforcement guys walk typically parents, but educators, people who are concerned about young people, walk you through and take you on a tour of this bedroom and all the crazy ways that young people are able to hide substance use, and signs that you just, if you weren't thinking about it, you might never notice that a person you care about, a young person you care about, might be in trouble with drugs. And I think we didn't know that coronavirus was coming when we did this, but I think it's very timely that because we aren't able to be in all places with the RALI Cares trailer, we actually have set up a virtual tour that you can take of the trailer. It's not as great as being in person, but it's at rallycaresvirtual.org. So that's RALI cares virtual.org, all one word, with the dot in there. So you can actually tour the trailer online. But one of the ways we've worked in some of the states where we don't have official chapters is that we've still taken the RALI Cares trailer to events in those jurisdictions, and given people a chance to go through it and explore and learn.
Well, I'll tell you that I know that we have Granges in places where you don't have official chapters. So I'm going to come back and ask what it takes to start one of those. But they have fairs. Obviously, this year is a completely different year than many others. But I know some of the Granges who have fairs have been interested in having different displays about different things. And an interactive one like that sounds like an incredible addition to something like this. So I will make sure to keep that in mind as well. But
I think that's one of the ways that RALI has been able to partner with some of the Granges is at the fairs and other educational opportunities, is getting the trailer there, holding conversations with members of the community about the risks and ways they can address them. And then also through one of the things RALI has done is through partners like the Grange, distributed prescription drug disposal kits. So I think that's one very simple way that every single family can be a part of addressing this issue, is just, and this is, coming from a person who, again, I've been in this field for about 12 years, that sometimes we just don't think about the dangerous things that we keep in our house, because we just, we may get a prescription for something that we needed at the moment after a surgery or an injury. But we were feeling okay after a few days, good enough that we didn't feel like we needed to keep taking them. And now they're just sitting in our medicine cabinet where, a friend who's struggling may come over and find them. A child may get a hold of them inadvertently, or a teenager on purpose. So just thinking about ways we can get those out of our house. And one of the ways is prescription drug disposal pouch that basically deactivates the chemicals in those medicines, so they're no longer effective. And it's a really environmentally safe way to, as we're trying to be good stewards of our resources, to protect the environment at the same time we're keeping our family safe.
I think that goes back to that education part, just knowing when you feel like you should dispose of something, why it's important to do it that way. Limiting the amount of prescription you get. I know last summer I had a major surgery, and I asked my provider specifically to only do a 3-day prescription. If she sent me home with one, I did not fill it because I didn't want more drugs in the house than I needed. Partially because I just didn't want to deal with that. But I also had remembered hearing a story about a woman who, my surgery was not very visible, but I had heard a story about a woman who had had a knee surgery, and an addict, who lived nearby saw her moving around, with clearly visible signs that she had had a surgery, and assumed that there would be prescription drugs in the house. There were, and she was hurt during a home invasion because of that. And I just thought to myself, that's something I don't want to worry about. And just that knowledge, made me, I think, better at knowing what was going on with my health situation. So all of these things that you guys are doing and allowing us to be part of doing, I think, are really important for people to kind of stop the feeding into the potential for addiction.
Yeah. So you just touched on something I think is important to understand about addiction, because people who have addictions can do some things that we really, are really objectionable. Breaking into somebody's home. We see these photos of parents who've overdosed in their car, and there's a child in the back seat. And these things are really unfathomable. I have 3 little ones. We were talking before we got on the Facebook Live. 3 little guys under 9, and I can't imagine putting them in the situation where they might see me do something like that. But and I kind of came into this field through more of the public policy arena, so it's been a learning curve for me over the years of like really what happens to a person biologically when they become addicted. And so just quickly, what substances do to a person when that person becomes addicted is they hijack a part of the brain called the limbic system. And this is the part of the brain that's responsible for some of our most basic instincts, like caring for our children, eating, finding shelter. This part of our brain really like drives us in the way that, I'm driven to protect my kids. It makes a person's brain believe that that substance is on that level of importance with those most basic needs. And at the same time, it damages another part of the brain called the prefrontal cortex. And that's the part of the brain that, when you're angry at somebody for cutting you off and your limbic system goes, that's a threat, I should do something about that. Your prefrontal cortex is the part of your brain that goes, whoa, 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 slam the brakes. It's not worth getting all hyped up about. So this is the part of the brain that allows us to sort of override that limbic system with rational thinking. So at the same time, you have this really primitive part of your brain saying, get the drug, get the drug, get the drug. You also have a damaged part of your brain that should be saying, whoa, you could get arrested. You could put your kids at risk. This really jeopardizes a lot your safety and a lot of things. And so I think, I just want to elevate that and say like, this disease is really devastating to communities and families, but also to that person who is suffering with it, who may do some things that we find really abhorrent. But then a certain amount of compassion, I think, is warranted because it really does organically affect those parts of the brain.
Mark, I'm going to go off script for a second. I'm going to just ask, since you kind of went into this description of what happens after someone has kicked the addiction, these parts of the brain are wired to almost spark into immediate action again if they're ever exposed to it. But do they ever fully recover from some of that damage done, even if they never touch a drug again? Because we're hearing that same thing about COVID, that some of these body systems that are getting damaged are parts of the body that don't typically recover from damage.
Yeah, no, I think it's a really important point. So there's a couple of things at play here. One is that if you've become addicted in the first place, you probably came to substance use with some pretty serious risk factors. Because there are hundreds of millions of people, there are tens of millions of people in this country who've used drugs, who drink occasionally and never really have a big problem. There are risk factors like genetics, histories of trauma, and the genes are interesting because it's actually, there's not like one gene like with breast cancer where you're like, this person has a really huge risk. It's a bunch of genes that control our impulsivity, our dopamine levels, like all these things. So you can't just like look at somebody's genetic code and say, yep, they've got it. But there are genetic factors. How early in their life somebody ever uses drugs and alcohol. So, if you drink earlier in life, you actually prime your brain throughout the rest of your life to be more susceptible to developing an addiction. So even if this person kicks that drug habit, they have all these pre-existing risk factors that would have made them more susceptible to an addiction in the future anyway. And then the brain is more primed, as you say, to develop an addiction and sort of like accelerate really quickly if they start using substances again. So that's kind of the bad side of the coin. The good side of the coin is the answer to the other part of your question, which is that these parts of the brain do heal dramatically. Even within the first month, we start to see improvements in the damaged brain tissue. And by a year, we see like dramatic improvements. I wish I could show you, I don't have them with me, but there are actually some really cool slides on the National Institute of Drug Abuse website, drugabuse.gov, where they actually show brain scans of a person a week after stopping using methamphetamine. And also, I think they also have images for a person who's addicted to cocaine. But the damage that you see is very similar. and then they show it a month later and a year later, and you can actually see these parts of the brain kind of like coming back online. And it doesn't look exactly like that brain did before they ever started using substances, but you do see like dramatic healing.
That's fascinating. So Minnesota has also chimed in, our state president from Minnesota, that they would like to be involved. And so we'll make sure to connect you all with them as well. Our local president of the Grange in Washington, D.C. asked a question about RALI, your organization, and CADCA, C-A-D-C-A, which is Community something, Anti-Drug Coalition Association. Right?
Yep, exactly.
Oh boy, it takes me a second to get that one.
That's pretty good.
And how you interface, or if there is any interfacing, because I know that we've sent some of our youth to training to figure out how to help, make sure youth are deterred from drugs in their communities. So I'm wondering if you could talk a little bit about the interfacing of those two organizations.
So CADCA, two things about CADCA. One, they are really like a preeminent authority on prevention in communities. So, you think of approaches to stopping drug use and addiction kind of falling into multiple buckets. One of them is prevention. How do we keep people from becoming addicted in the first place? Another is treatment. How do we address the healthcare needs of people who are addicted? And then the third bucket is harm reduction. How do we keep people safe in that time in between, when they may start drug use and when we can convince them that it's time to get treatment and stop this drug use? And CADCA really are they are among the top authorities on prevention. So, and RALI, CADCA is one of the original national partners of RALI. So RALI it's not a membership organization, so I wouldn't call CADCA a member, but they really are like one of the founding groups that were involved in getting RALI started. So work very closely with them, and a great deal of our work around prevention is informed by what CADCA says works. And a big part of that is working through, they are sort of an umbrella group for the anti-drug coalitions that are in different parts of the country. And those coalitions are funded by the federal government. And CADCA sort of provides resources, education, and sort of a convening body for those coalitions throughout the country. I think probably in sort of a similar way that the Grange has state and local groups and sort of forms an umbrella to coordinate and convene and raise up best practices and things like that.
Do you mind talking a little bit about your structure? And I know obviously we have some states now interested in potentially being, kind of one of those founding partner groups in their state. What is RALI's structure? What's the benefit of having a state chapter if you do have some resources available to you, and how do you get state chapters?
Yeah, so few things. So the structure of RALI is it's a 501c3 nonprofit, and the management of it is mostly kind of through contractors. I'm not an employee of RALI, but work as the policy director and help getting some of the chapters off the ground. I'm not the person with the authority to decide about new chapters and prioritizing that. I think the big thing with the new chapters is sort of a combination of gauging interest of partners in those states, and prioritizing states where sort of the need is the greatest, but also not wanting to grow so quickly that we're not able to serve the needs of existing partners. So the organization as a whole is only a couple of years old, and so growth has been pretty rapid to have 14 groups throughout the country. I think the benefit is a little bit greater access to the resources that RALI brings to the table. One of our founding partners is PhRMA, the Pharmaceutical Researchers and Manufacturers of America, who's really committed some serious resources to getting this off the ground and making sure that partners are able to get the drug disposal pouches, host events, and things like that. So I think that's been one of the huge benefits. easier to kind of get events scheduled if you want to have the RALI Cares trailer come, and having those regular meetings where the coalition actually, gets together right now virtually, to talk about what they're seeing in their community, what's working, and sort of like what are the next steps that can be taken. And we stay away from policy advocacy, so we don't do any lobbying, but we do try to kind of stick in that raising awareness, and kind of raising up examples of what's working kind of space.
We've kicked the dust on this topic a dozen times in this conversation, so I guess it's time now to either wash the baby or get rid of it. I'm not sure which. COVID has changed life, period. And it certainly has changed the life of people who, weren't taking any type of drugs. So those folks who were, especially those folks who were seeking treatment, right before or at the beginning of this crisis, things have completely accelerated in a lot of ways, and also slammed on the brakes in a lot of ways. What's happening with the opioid crisis? What's happening with people who are trying to get treatment?
Yeah. So it's a really big question. And I will say, as much as this crisis, the coronavirus, has sort of captured our national attention, and I mean, it's, I don't know about you, but it's something that I think most of us think about every day and kind of have intruding on our thoughts on a pretty regular basis. But I think we also have to remember that it's, it's the novel coronavirus, but it's also kind of a novel experience that we're all going through. And so I'll say most of what I'm saying I would take with a grain of salt, because we really don't have definitive answers yet about how this is all going to play out. But we do have some concerns, and some anecdotal evidence of things that are issues that we expected, and some I think that have been a little bit surprising. So I'll start kind of like with, what did people in this field expect when this all started? And I think that you started to touch on a couple of things. One is the interruption for people that are in treatment. So drug treatment is typically, for all drugs and alcohol, involves in-person counseling. And some of that's given in a group setting. Sometimes it's one-on-one. I think more typically you wind up in group settings. Usually meeting, once a week to 3 times a week to every day. And so immediately we thought, well, this is going to be interrupted for a lot of people. In rural communities, I think, the problem, the change that this meant was going to take place is actually a little bit less severe, because in rural communities, we already were starting to see an acceleration towards some of these services being provided by telehealth, just to improve access, because you don't have the density of population to have, like in Baltimore, where I used to work, an addiction treatment provider on every 6 blocks. And so a lot of these services were already being provided by telehealth. But for a lot of the country, that wasn't the case. And so we've seen a real acceleration towards telehealth counseling, which I think is a good thing in general for access, and something I hope will continue when all of this is over. But I don't think my personal perspective, and I think what people expect, is it's not quite as beneficial as being in person. I think, we're having a great conversation. I'm really enjoying talking to you, Amanda, and hope people are enjoying the conversation. But it's not the same as being in a room together. I can't, I can see your facial expressions, but I can't read all your body language. I'm not picking up everything that you're putting down. And the same is true for me, I'm sure, for your ability to kind of read what's going on with me. And so we don't get the full social experience in a virtual way. And that also means that that's true for people who are in recovery. People can be in recovery for years and still rely on a community to keep them in recovery, whether it's AA, NA, Smart Recovery, sort of formal recovery groups that meet and people attend those meetings being disrupted. Or, we talk about addiction as a disease of isolation. And now everyone's got to isolate, right? So what we say is the opposite of addiction is community. But now we're saying that people can't be together. And so I think one major concern is, and I think that this will come to pass, I don't know what the scale of it will be, is that many people who were very secure in their recovery, unfortunately, are going to relapse. and we're going to have a whole new wave of addiction that includes opioids, but also all the other drugs and alcohol that people have been addicted to. And we've got, I talked about the 20 million people who are addicted to drugs or alcohol. There's 23 million people who are in recovery. And I think, unfortunately, a certain percentage of those folks are going to be at risk, because the other thing is that drugs and alcohol are a coping mechanism that people in our society use pretty frequently when they're stressed out, when they want to, get some sleep, when they're worried about something. And this is a time when a lot of us are stressed out and worried. And that's also true for people who are in recovery. So I think I worry about the overuse of drugs and alcohol as a coping mechanism among people who have been stable in recovery, but also people who maybe have not used substances to excess in the past. And so I think we will see either a mini explosion or a big explosion in the number of people who are actively using substances in a way that is harmful to themselves, or who are, really developing some serious addictions. The other big concern is around harm reduction. And this is kind of, I will, just acknowledge here, harm reduction is something that I believe very firmly in, but I also know that people have very kind of varied opinions about harm reduction. And so I just want to pause and acknowledge that not everybody agrees that providing sterile syringes is something we should do for people who use drugs, or naloxone. My personal opinion is that this is something we should be doing. It slows the rate of infection, and we find that doesn't increase substance use, and that people sometimes, when they're ready to get into treatment, the way that they get there is through harm reduction programs that are able to connect them. So, but all that aside, harm reduction programs are not operating at full capacity. In some places, they're not operating at all. And anecdotally, we are hearing there is a nonprofit that distributes clean syringes through the mail, and that they are just getting inundated with requests from people who formerly were getting these services locally in their community, and describe really just, disgusting hygiene that people are using, because they are still severely addicted, have that limbic system telling them they've got to use these substances, but they don't have access to clean clean syringes or other things they need, and are reusing syringes multiple times, sharing syringes with other people. And so I think we're also going to see an increase in hepatitis infections, HIV infections among the drug using population. And the other part about harm reduction that I think has maybe wider acceptance is the distribution of naloxone, so that people who are using drugs, if they overdose, somebody can save their life. And I always talk about, we can't make somebody's tomorrow better if we don't save their life today. And part of naloxone is that if you're overdosing, it's very, very, very unlikely that you're going to be able to give this to yourself. So one of the things that harm reduction groups teach people who use drugs is to never use alone. But now we're all saying, you got to be alone. And so I think we will also see that there are an increased number of overdoses that result in death, because nobody's there to save people. And our first responders are overwhelmed with calls related to coronavirus. Our emergency departments are really focused on providing the capacity to address the coronavirus. And so another thing we don't necessarily think a lot about is that now, with all these additional protocols for first responders, their time to address a call is delayed, because they've got to, change out the personal protective equipment every time. There's more that they've got to put on. If they think they've been exposed, that entire ambulance has to be put out of commission until it's been thoroughly cleaned. And so our calls are being slowed down. So I think when the data start coming out, we're going to see increased rates of overdose death. Now, the flip side of this that I just started to learn about, and again is sort of anecdotal, is that the drug supply has gone down. So when this all started, when we all started kind of socially isolating and borders were being closed down, people who were involved in international drug trafficking organizations, especially from Mexico and South America, returned home, and the border closed. And so we're actually seeing less, lower volumes of drugs getting trafficked into our communities. And anecdotally, some communities are saying, like, there's nothing. And now people seeking treatment from withdrawal has gone up. And, I think that has the potential in some cases to be a really good thing, where people are kind of forced into this, like, okay, I'm going to have to go through withdrawal now. And the only way to do this is, to go through it and then to get into treatment. And so I think on the one hand, we're probably going to see some of that. The unfortunate side effect I'm anticipating from that is something that we often see when people come out of the criminal justice system or residential drug treatment, is that people don't understand how much their tolerance has gone down. And so if they go out and decide to use drugs again and they think, oh, well, here's my normal dose, their body can't handle that anymore. And so I do think we'll also have an additional wave of overdose deaths that will hit as a result of that.
I just want to mention that, you talked a lot about syringes, and I think that surprised a bunch of folks, because anybody who hasn't really paid a ton of attention to the issue, because they've been very fortunate to not have to, may not really think about the injection part that comes with a lot of this opioid use. They think about the oral use of the pills that they would get if they were prescribed pills, or they think about heroin, and sometimes they think it's something that you snort or swallow. But
it can be.
Yeah, right. But in fact, in a lot of cases, it's something that's taken by syringe, so it's intravenous. So if we
and that's part of the acceleration with this drug. So our bodies can tolerate, if they're trained, can tolerate I would say an insane potency and dosage of opioids. And people's tolerance goes up for these drugs really fast. And so people may start out, taking pills either for a prescription or for fun or whatever it is. And then all of a sudden they're taking more and more of those pills. And because their tolerance has gone up, and all of a sudden they need 2, 3, 4 times what they were getting before. And now they've decided to crush up the pill and snort it, because that delivers it to the bloodstream more quickly, and they can get that high more easily. Well, then that just increases their tolerance more, because that's hitting the bloodstream so fast that what they're getting is really like a massive dose, and then a quick drop off too, because that's the other part, is this cycle of getting high and then feeling like crap because it wears off, gets accelerated. And now all of a sudden, people who would never have considered injecting a drug are like, that's the only way I'm not going to feel sick.
So, I mean, when we're talking about, partnering and doing things, we are talking about the spectrum of types of drug use. And I think that's kind of an important thing to say, because if you're doing a drug disposal or, whatever, a safe disposal day or whatever, you may have folks who come with needles and things like that. So just something, if you are considering working in this sphere as a Grange, you just have to understand that it is all of the spectrum of drug use that you see with opioid use, the types of taking it.
Yeah, and you should not be accepting, unless you have a professional there who can take responsibility for syringes. Do not accept syringes from anyone.
Right.
Sorry.
No, I'm glad you said that. I know that I've had a friend in a different organization where they did kind of a safe disposal day.
Yeah.
Said somebody who had a relative who had been addicted kind of gathered up all of the old syringes and brought them, because this was used.
They wanted to get rid of them. Yeah.
Get rid of them. And it was a surprise, I think, to people who weren't expecting to have anybody bring that.
Absolutely.
So when life gets back to normal or more stable, or whatever we're going to call this, what are groups like yours most concerned about, besides that tolerance level being reduced and then having the potential for a lot more overdoses? I mean, I'm thinking we're spending money like crazy on a lot of things. Will there be money left for some of these programs that you guys are involved with? So what were you finding as some of the biggest concerns for after COVID?
Yeah, I mean, I think some of them obviously relate to just what this means for people who have been in recovery and doing well, people who were in treatment and now have had it interrupted, that risk around overdose. So I think broadly, those are some of the top kind of substantive concerns. Another thing is that we've completely stopped doing research on an issue that we were just starting to kind of like figure out what to do about it. And you know, I think that there's a possibility that some callousness around the scale of the opioid epidemic could develop after we see a viral epidemic. That, you know, again, my perspective is this is an organic disease of the brain. So there, for me, there's no moral judgment, but I think that there is also a perspective that people have, that I understand, that is that, you know, if you're using drugs, there's some fault. And we're talking, and in the midst of a virus that we have no control over, you can't really do anything besides wear a mask and stay home to protect yourself from. We're seeing people die who you might say like no fault of their own, and larger numbers than we're seeing from the opioid epidemic now at this point. My concern is that we're not going to pay attention to this other epidemic in the same kind of serious way that we have in the past. On the other hand, I think that communities and people have really come together around this issue. And I don't think that, you know, I think that there are going to be a lot of changes in our society, but I don't think it's going to like fundamentally alter the fabric of our society in a way that means that we stop caring about people and families. And you know, I think part of you asked earlier about like what brought all the attention to this, is that every community has been affected. Every socioeconomic group has been affected. And so everyone either knows someone or knows somebody who knows somebody who's lost a child. And I think our you know, Americans have good hearts. I think we'll be back in the fight. And I'm pretty hopeful about that.
I am really excited about kind of like the territory that we covered today. I feel like, you know, we've hit a ton of subjects. I want to remind our folks that if you have questions or comments, to put them in the comment section now, since we're kind of wrapping down. So I'll give you another minute or two to get those comments or questions in there. And I know we're on a slight delay. So I'll ask my last part here, which really is kind of the same that I asked most people. And that's what didn't we hit here that's especially important for an organization or for people, you know, who cluster in our organization to know in order to be better partners? You know, what didn't we cover?
I think, you know, we touched on it a little bit, and I guess this advice is maybe not super timely right now, given that we're all supposed to be apart. But my experience around this issue is that so many of the good solutions happen when people just get in the room together and start talking about it. In a place that makes people feel safe to talk about how this has affected the people they care about, whether it's in their family, themselves, their neighbors, to really identify like, what do we think is working that isn't? What's not working, but we can solve pretty easily when we just get together? And then what's that like leftover group of problems that we can identify that's a little trickier to solve? And let's start working on those. And you know, Pickaway County, Ohio is one of my favorite places. It's a rural community that I got to do a lot of work in when I was with Addiction Policy Forum. And we had a stakeholder convening where like 60 leaders from this community came to talk about how this was affecting their, you know, their child welfare system, their schools, you know, and 80% of the issues that were identified in the room were solved in the room just by people who lived near each other talking to each other about what the issues were. And, you know, the child welfare system would say, well, we're having a problem finding this resource. And somebody else in the room says, that's what we do, you know? And so just, we got to talk a little more about this. I think the more we can talk about this issue in a compassionate way that you know, doesn't reflect judgment about people and families, the more comfortable that as a society we're going to be just talking about this issue. And I think that means that more people will seek help early on when they need it, instead of waiting until, we talk about rock bottom. The idea of waiting till rock bottom to me makes no sense when this disease is very progressive. And like, if you can get somebody help, or they can seek help when they're just starting to have a problem, this disease is a lot easier to address than when their life is in shambles and, they've gone from, drinking every day to drinking like a case of beer every day to drinking, a bottle of liquor every day, or gone from taking pills to injecting heroin. Like, let's start early. And the way we do that is by being comfortable talking about
The thing I think I just wanted to highlight, as we're getting wrapped up here, and I don't see any other questions, so I'm going to assume there won't be any. But is, you mentioned that addiction is a disease of isolation, or a part of isolation is part of this equation. And I for one just know that no matter what group you are, not every group or every Grange or every library association or whatever is the place to help beat that isolation for people who are addicts. Because of just what you talked about, some barriers and attitudes, some barriers in perception or expectation or personal experience, that they're just not willing to move past. But I think for Granges that are, willing to find ways to provide opportunities for folks who are struggling or could struggle, have all the markers to struggle, to provide them opportunities so that they are not isolated and don't start down a path that will be very hard to get off of. I think, that's what we do best. These cultivating connections, we've heard it so much, how much we are good at connecting folks. And so I would just say that, I hope that our Granges who are equipped with the right attitudes and the right interests would step forward and provide some of those opportunities for people to feel not so isolated. And Mark, I'll just leave it with asking you, how important is that as part of this process, that community organizations like Granges, churches, Lions clubs, whatever, go out of their way to include people who otherwise they may not, so that they have a game night to go to instead of a friend's party where they're going to have these things at their disposal.
Yeah. So I'm glad we got here, because this actually kind of circles back to the beginning of our conversation. And I think that if you hadn't kind of led us in this direction, this would have been the most important thing that we didn't talk about. So thank you for bringing it up. We started out talking about why it's important to have partners, because our society has become so fragmented. And, who the trusted voices are varies for different communities and different individuals dramatically, I think in a way that has not historically been the case. But another part of that fragmentation is that, and I think one of the major drivers of this epidemic that we didn't touch on earlier, is that people are just not as connected to community as they used to be. We have, declining numbers of people who regularly attend church, declining numbers of people who participate in Rotary clubs and Lions clubs, and I don't want to speak for the Grange, but I would imagine declining numbers of people who participate just in general in institutions that used to really be like fabric in the community that glued people together. And all that to say that, we talked about addiction being a disease of isolation. And we talked about those genetic risk factors that you have no control over. If you've got them, you've got them. But one risk factor that you do have control over, and I would especially encourage anyone who's interacting with young people to really think about, is that one of the greatest risk factors for addiction is isolation, and one of the greatest protective factors, so those things that make a person less likely to develop an addiction, is involvement in the community, whether it's sports, church, clubs that go camping, 4-H, whatever it is. Being involved in a group is an incredible protective factor for young people. sort of period. Like that is just a scientific fact that we know from research. And so if you know a young person or you're a parent, that's a big warning sign. If they start dropping out of those things that they used to be involved in, that's a big warning sign. But one of the greatest things that you can do for a young person is get them involved. Make sure that they know that there are adults and other people their age in the community that care about them, want them to be successful, want them to be healthy and happy. Part of that community and part of one of those big protective factors is having a relationship with any adult outside of your parent group who you know cares about you. So parents are hugely important. Having involved parents, huge protective factor. But then also having another adult anywhere, a coach, a mentor, another family member who really shows that they care about you is a huge protective factor for kids. And then being involved in the community.
I apologize. I'm apparently ringing. That's the first time this has happened because I totally forgot to put that on airplane mode. Mark, I think you hit the nail on the head. The thing that we don't talk about. I mean, it's really hard because you don't want to say join the Grange. It will legitimately completely change your life because we're protecting you from all of these things. I could say join anything that is, reasonable and good and involved in the, making you involved in the community. It will change your life, right? It's hard to brag, but let's do it because any one of these groups like us, can have that effect. So I'm really glad we got there and we closed with that. So,
Sure.
So thank you for that.
Thank you.
I know that we have a lot of folks out there interested in working with RALI, whether it's in a state chapter that you already have or hosting, the trailer or doing something else. So I know that we'll be in touch. Burton Eller is typically our contact, and I will defer to him on connecting you to especially Minnesota and Texas, like I noted. But I hope that we will continue to be in touch. And as you grow out your network, after this crisis kind of comes to at least resolves a bit, you'll be able to come back here and tell us kind of where we are. Hopefully one day we're coming back and celebrating a bit of what's gone on, or you're able to say, this is something that we've pinpointed that works really well and Granges can do it easily.
And maybe we could sit in the same room and talk about it.
That would be wonderful. Yes, please. I am such a people person and I need people and I'm missing people. So my dogs have gotten smothered recently.
Seeing it, not live and didn't get to ask a question, you can always reach out to us at info@rali.org. So it's info, INFO, at rali, RALI.org.
Perfect. Just what I was going to say. If you have questions, you could send them to me and I can send them to you, but send them directly to him. That's fantastic. Mark, thank you so much for joining us and for taking us on this kind of journey of looking at what's happening in this realm that affects so many of us in many, many ways. So thank you so much
for having me.
Absolutely. Tomorrow we will see Burton Eller. We've spoken about him a couple times. He's our legislative director. He'll be giving us an update from Washington, what's happening with the HEROES Act, which was passed out of the House, but went to the Senate DOA, and several other things going on in Washington and beyond. If you have questions, you're welcome to submit them to me in advance, or tomorrow at 4:00 Eastern, we'll start here again. So we welcome you back to that. And don't forget, if you're interested, sign up for our trivia night on Friday. If you know somebody who is isolated, consider sending them the information. It just may be life-changing. Thank you so much again, Mark. Everybody, please stay safe and wash your hands.